Hi everyone, and welcome to our module on bias. Bias refers to a systematic error in a study, either an epidemiology study or a clinical trial or a research study. And there are a couple of ways that studies can be flawed because of bias. First of all, there can be a problem with the selection of the group you're going to study, and we'll talk more about this in a minute. There can also be a problem with measurement. You could have a problem assessing the outcome or assessing the exposure in a research study. And then finally, there can be problems with something called confounding, which is when an unstudied variable affects the outcome and is different between the two groups you're comparing. And so we'll talk about all of these things in the rest of this video. We'll start by talking about selection bias, which refers to any error in selection or retention of the groups that you're studying. And usually when we use the term selection bias, it's a general term, meaning some problem selecting the groups of patients that we study so that our analysis of those patients is incorrect, or so that the findings are unique to those patients and aren't applicable to the general population. And there are many different subtypes of selection bias, and I'll go through some of the important ones in the next few slides. We'll start by talking about sampling bias, which is a subtype of selection bias. And this refers to a study in which the patients are not representative of actual practice. So there's been a bias in the patients that you sampled, and when you try to apply the findings of your study to the general population, it can't be applied because the patients in your study don't match the general population. So for example, the average age of many heart failure patients in clinical trials is 65 years old. The average age of heart failure patients in actual practice is over 80. So in my field of cardiology, we always have to question when we're applying heart failure trials to an older population whether or not the results are applicable. And we always worry about sampling bias leading to a disproportionately younger population in the trial. Attrition bias is another subtype of selection bias that can occur in any prospective study where you follow patients forward over time. When you do this, some patients can be lost to follow-up, and if the patients that are lost to follow-up are unequal between the groups, then that can lead to results that are biased because of attrition bias. So for example, suppose 100 smokers were lost to follow-up due to death, and you were studying the effects of smoking on health. Your study might show that smoking is not harmful, but that's because 100 smokers who died were lost to follow-up. So in any prospective study, you always have to pay close attention to patients who drop out of the study. You have to make sure you can understand why they dropped out and make sure there isn't an unequal loss of patients between the different groups that you're comparing. Bergson's bias is another subtype of selection bias, and this type of bias occurs when hospitalized patients are used as the treatment or control arm in a study. In general, patients who are hospitalized tend to have more severe symptoms. They also tend to have better access to care because they have a nurse at the bedside and a doctor on call. And so both of these things can alter the results of a study. So for example, suppose there was a study of hospitalized pneumonia patients, and the study found that many pneumonia patients have a history of stroke and that pneumonia is associated with stroke. But if you did the same study in the community, you might find no association, and that's because stroke is a marker of an older patient who may have more comorbidities, and that's the type of patient that's more likely to be hospitalized. And so in any clinical study, when you're going to use hospitalized patients, you have to be aware of Bergson's bias and make sure your patients are representative of populations in general. Non-response bias or participation bias is another subtype of selection bias. This occurs with survey and questionnaire studies. Non-responders to your survey or your questionnaire are obviously not going to be included, and the patients that do respond may represent a selected group. So anytime you're going to publish findings of a study where you sent out a questionnaire, you have to be aware that the people who responded may be a selected group, and that your study may be vulnerable to non-response or participation bias. Prevalence bias, which is also sometimes called Neyman bias, is another subtype of selection bias. This form of bias occurs in studies trying to associate exposure with disease, where exposure occurs long before disease assessment. When this happens, when there's a big time difference between exposure and assessment, patients who die quickly are not going to be included. So if you try to study the prevalence of disease and whether or not patients who have disease have been exposed in the past, you're going to get a select group of survivors in your study, and that can lead to bias in your results. A sort of similar type of bias is called length time bias. This refers to the fact that patients with severe disease do not get studied because they die. So for example, if you do a study of HIV patients, it might show that the disease is usually asymptomatic. And that's because patients with severe forms of HIV may have died already. And so if you try to estimate survival, you might overestimate survival because you're missing all those severe cases and only getting the milder forms. This can also sometimes happen with screening programs that identify only slow-growing tumors. So it'll make the screening program appear effective because you're only identifying the slow-growing tumors. Tumors that grow more quickly lead to death more quickly, and therefore those patients don't end up in your study of screening. And then lead time bias sounds like length time bias, but it's a different form of bias. This refers to when screening identifies disease earlier, and it can make survival appear longer even though it's not. So if you look down here at the bottom of the screen, this is when cancer would normally be detected based on symptoms, and this is what the perceived survival time would be if you looked at the survival of cancer patients who were diagnosed based on symptoms. Now, if you introduce a screening program, you might diagnose cancer earlier before it would normally be diagnosed, and this leads to what's known as lead time. This is extra time that the patient is alive after being identified, and this will make your perceived survival time appear longer, even though it's not. All you did with your screening program was detect patients earlier. So for example, if you think about breast cancer, suppose that the average time from detection of a breast lump clinically to death was 5 years. You have a screening test, it identifies breast cancer earlier, and it shows a time from detection to death of 7 years. This will make it look like your screening test is very effective, but really all you're doing is identifying patients earlier than they otherwise would be found, and you're not actually increasing survival with your screening program. The way studies try to avoid lead time bias is by controlling for disease severity. So when you detect patients with your screening program, you compare their survival to the expected survival based on the stage of disease at detection. And this will give you a better idea of whether your screening program is actually improving outcomes and not just detecting disease at an earlier, milder stage. The term measurement bias can mean any bias in a study caused by the way you measure exposure and outcomes, but often when people use this term, what they're really referring to is sloppy research technique. So for example, if you were measuring blood pressure incorrectly in one arm of patients in the study, that could lead to measurement bias in the way you measure blood pressure. Basically, if your researchers aren't following the protocol that you develop, then measurements of exposure and outcome can be assessed improperly. And this is avoided by standardizing the way data are collected. Researchers try to always collect data in objective, previously tested methods that are known to work, and these are carefully planned ahead of time. So for example, in clinical trials where you're going to assess blood pressure, ahead of time, the trial designers specify exactly what cuff's going to be used, what time of day the blood pressure will be taken, how it will be measured, and they make sure everyone does it the same way in the study, and that's to avoid measurement bias. So as I said on the last slide, sometimes the term measurement bias is used to simply describe any error in measuring exposure or outcomes. And so when you think of it that way, recall bias is a subtype of measurement bias. Recall bias refers to inaccurate recall of past events by study subjects. And this is a common problem in studies that involve surveys. They ask patients questions, they ask them to recall past events, and sometimes their recall of past events is inaccurate. So for example, if parents of disabled children were asked about lifestyle during pregnancy, and pregnancy occurred many years ago, then parents may have poor recall, and that could lead to inaccurate findings about which elements of lifestyle during pregnancy are associated with having disabled children. And the way you avoid this is by minimizing the recall time frame. You try to question patients shortly after the event you're interested in, not many years later, so that you can get accurate recall. Observer bias is another form of measurement bias. This occurs when investigators know the exposure status of the patient, and that biases their observations. So for example, if a cardiologist is interpreting EKGs for a study, but the cardiologist knows which patients have coronary disease and which do not, this could bias the observations about the EKG. Similarly, if a pathologist was reviewing specimens, but the pathologist knows which patients have cancer and which do not, this could also bias the observations. And this type of bias is avoided by blinding, which refers to not allowing investigators to know the exposure status of the patient. So in many drug trials, investigators do not know whether the patient in the study that they are taking care of received the experimental drug or a placebo, and this helps to make sure that there won't be any observer bias where investigators interpret the findings in the patient based on knowing their exposure status. And then procedure bias occurs when one group that you're studying receives a procedure like surgery and another group does not. The patients who have surgery often get more care and attention in the post-op period compared to patients who do not get surgery, and this can lead to differences in outcome that are unrelated to the surgery but are in fact related to the care and attention that patients get after they have had surgery. You can avoid this by blinding, also called masking. This is where the team caring for the patients is unaware of which patients have had the procedure and which have not. For some patients where there's a large incision or wound, it can be very hard to hide whether or not the patient has had the procedure, but if possible, you can do that. This is also sometimes avoided by using a placebo, which can be done in procedural studies. There are some examples of studies where a sham surgery is performed. The patient has an incision, but surgery is not done, and then afterwards the patient and all the people caring for the patient are unaware whether or not surgery was done, and therefore you can assess outcomes and avoid any type of procedure bias. Okay, next let's talk about confounding bias. This occurs when an unmeasured factor confounds the study results. So to understand this, consider that a study found that alcohol users are more likely to develop lung cancer compared to non-users. This might make it look like alcohol is a possible causative factor for lung cancer. However, smoking is much more prevalent among alcohol users, and smoking is the true cause of more cancer. So in this example, we would say smoking is a confounder. It's an unmeasured third factor outside of alcohol and lung cancer that is the cause of the studied results. The way epidemiology studies manage confounders is by doing what's known as a stratified analysis, which eliminates confounding bias. So to understand this, let's look at this 2x2 table I've set up here. We have lung cancer along the top and alcohol use along the side here. And let's imagine that our epidemiology study found these numbers for cases of lung cancer and alcohol use. And in another video, I talk about how you can calculate a risk ratio using these numbers from a cohort study. And in this example, the risk ratio is equal to 5, meaning that lung cancer is 5 times more likely among individuals who use alcohol compared to those who do not. But if you're worried that there might be confounding bias in this example, you could stratify the results based on whether patients are smokers or non-smokers. And so if you do this, you might get a 2x2 table like what's shown at the bottom here. These are just made up numbers to illustrate this example. But in the stratified analysis, under smokers, the relative risk is equal to 1, and under non-smokers, the relative risk is also equal to 1. So what we've shown here is that when you break down the analysis based on whether patients are smokers or non-smokers, the risk association that you found in the original study goes away. And that's because all of these findings in the original study are related to whether or not the patients smoke, not whether or not they use alcohol. And so when you analyze the smokers separately and the non-smokers separately, you're not going to find any association because now you've taken smoking out of the equation. There are a couple of ways you can control for confounders when you're doing clinical research. If you're doing a clinical trial where patients are assigned to, for example, a drug or placebo, then you can randomly assign them to one group or another. And this should make sure that there are equal variables in both arms of the study. And I talk about this in more detail in the video on clinical trials. If you're doing a case control epidemiology study, the way you control for confounders is through good matching. So you want to have a very careful selection of your control subjects in a case control study to make sure the controls match the cases as closely as possible. So you want to choose patients with the same age, gender, smoking status, and that way when you get a result for an association between an exposure and disease, it won't be due to some of these other things because you've carefully matched the controls to the cases. So that's a nice segue into some of the ways you can reduce bias in clinical studies. As I said on the last slide, randomization is great for limiting confounding. It also eliminates selection bias between groups. If you randomly assign patients to, for example, a drug arm or a placebo arm of a study, then you shouldn't get selection bias in terms of who receives the drug or who receives the placebo. In case control studies, you can match the groups carefully. We've already talked about blinding. And then another way to reduce bias is called a crossover study. So let's talk about that now. In a crossover study, subjects are randomly assigned to a sequence of treatments, meaning they receive one after another. For example, Group A might receive a placebo for 8 weeks followed by a drug for 8 weeks, and Group B might receive the drug first and then the placebo afterwards. The nice thing about studies like this is subjects can serve as their own control. You can compare outcomes in an individual subject when they were on the placebo versus when they were on the drug. And this should avoid confounding because it's the same subject. You're comparing an individual person to his or herself. There is a drawback, and that's that the effect can carry over. So after you stop the drug, the effects can carry over into the placebo period. So to avoid this, crossover studies usually have what's known as a washout period. So this is the way a crossover study might work. Group 1 might get the placebo for 8 weeks, and Group 2 might get the drug for 8 weeks. Then there's a washout period of maybe a month or so, and then the groups switch so that Group 1 gets the drug and Group 2 gets the placebo. And so there are certain types of clinical studies in which this design is very favorable. For example, if you're studying the improvement in chronic pain on a pain medication, this can be very helpful because patients can have some improvement during the placebo period from a placebo effect, but you can directly compare any change during the placebo period in each individual to a change that occurs during the drug period. Okay, next let's talk about effect modification, which is not a type of bias. This is a point of confusion sometimes. People think that effect modification is bias, but it's not. However, it's very similar to confounding and can be easily confused with confounding, so let's talk about this now. Effect modification occurs when a third factor alters the effects of a clinical study. So suppose, for example, drug A is shown to increase the risk of deep vein thrombosis. But to cause deep vein thrombosis, drug A requires gene X to be present. This means that gene X is an effect modifier that modifies the effect of drug A. You can identify effect modification from a stratified analysis like we talked about for confounding, but the findings are different than what you would see if there was a confounder present. So for example, suppose we got this 2x2 table for deep vein thrombosis occurring in patients who did or did not receive drug A. And if you do the math, this table will give you a relative risk of 5 for DVT in patients who take drug A. But if we stratify the analysis into patients who are gene X positive on the left and patients who are gene X negative on the right, what we see is the relative risk of 5 persists among the patients who are gene X positive, but the relative risk goes away and becomes equal to 1 in the gene X negative patients. So in contrast to confounding, where the relative risk was 1 in both groups in a stratified analysis, in an effect modification scenario, the relative risk will persist but only in one group, and that tells you that that subgroup contains an effect modifier for the drug you're studying. So just to make the difference between confounding and effect modification clear, in confounding, a third variable distorts the effect on outcome. Remember the example we talked about with smoking and alcohol. Alcohol appears associated with cancer, it appears to have a positive association, but the real effect of exposure on outcome is distorted by the confounder of smoking. And when you stratify for smokers and non-smokers, the effect of alcohol completely goes away. In effect modification, a third variable maintains the effect you find in your study, but only in one group. So there is a real effect of exposure on outcome, but that effect requires the presence of a third variable, and that third variable is called an effect modifier. So to make this even more clear, let's go through an example, and let's imagine that patients taking drug A are found to have increased rates of lung cancer. So there appears to be an association between drug A and lung cancer. However, drug A is taken mostly by smokers, and so when you break down the study data into smokers and non-smokers and do a stratified analysis, you find no relationship between drug A and cancer, and that's because smoking is the real cause. In reality, drug A has no effect on lung cancer, and so this is an example of confounding of the association between drug A and lung cancer by smoking. In another example, let's also imagine patients taking drug A have higher rates of lung cancer according to a study, but drug A activates gene X to cause cancer. So when you break down the data and do a stratified analysis of patients who are gene X positive or gene X negative, the relationship between drug A and cancer will persist, but only in the gene X positive group. This means that drug A does have an effect on rates of lung cancer. This is different from confounding, but drug A requires another factor, which is gene X, and this is an example of effect modification, which, as I said before, is not a form of bias. Alright, moving on, let's talk about the Hawthorne effect, which is another example of measurement bias. This occurs when patients who are being studied improve because they're being studied and monitored. This can happen if patients or the providers taking care of them change behavior based on the fact that they know they're being evaluated. And this is common in studies of behavioral patterns. So for example, if physicians know their patients are being surveyed about vaccination status, the physicians may vaccinate more often, and it will look like physicians are being more careful to vaccinate everyone than they are in reality if you weren't studying them. Another example is patients who are being studied for their exercise capacity who decide to exercise more often because they know they're going to be asked about it. A different but somewhat similar form of bias is called the Pygmalion effect, also known as the observer expectancy effect. And this occurs when a researcher believes in the efficacy of treatment and this influences the outcome of the study. So for example, imagine if the creator of a new surgical device was overseeing a study of its benefits in patients. That creator might assess the outcomes very positively among his or her patients because they created the new surgical device and they want it to work and they believe that it works. And so this is another reason that we try to blind providers from knowing what treatments their patients have received. That way, if the provider has an opinion about whether the treatment is beneficial or not, that opinion can't influence their assessment because they don't know whether or not the patient has received the treatment. And so like I said, the Pygmalion effect and the Hawthorne effect are different, but they share some similarities and they can be easily confused. In terms of the Pygmalion effect, this occurs when the provider believes in treatment and influences the results to be positive. So this is unique to the investigator driving the positive benefit of the findings of the study. The Hawthorne effect is a more general term used to describe when subjects or investigators simply behave differently because they know they're being studied, similar to the examples we talked about earlier for vaccination or exercise status. And that concludes our module on bias.